details been changed to protect confidentiality. Sam was referred to the Learning Disabilities team following a whole load of repeated periods of ill health. He was in and out of hospital probably as often as every month, sometimes more frequently than that. And he had problems that actually were seriously life-threatening. He's got a profound learning disability. He has no spoken communication. So he's a young man with obviously already a limited life expectancy because of his physical disabilities. When he was referred to us, there were really major concerns because every time he went to hospital, he was facing lots of barriers, and it took a long time to get any sort of treatment, even though he was going in and out all the time. Sometimes he was waiting 12 hours in A&E before anything would happen. And nobody seemed to be identifying pain, and they weren't identifying health issues in advance, so there was nothing going on to kind of prevent admission. This is his HEF profile. What you just saw that Dave was showing you will then produce you, once you've filled in all the boxes, will produce you with this screen. It's really clever. Anybody who's technologically challenged like me will be pleased to know you have to do nothing but fill it in and it does it for you. The idea of this was, when we created it, we wanted the red on the outside to show the further out it was, the worse the situation was, and the green on the inside. Actually, if we could have done, we would have made it a bit redder and a bit oranger and less green so that you can see that, but you get the general idea, because this is on an Excel spreadsheet, and obviously you've got the limitations. So you can see that he's got major health inequalities, particularly in relation to communication and to his biological and genetic areas of need, but actually was scoring quite highly on the HEF score overall. And it also produces this lovely table, so you can see where he was scoring highly. So on there you can see that in the genetic and biological, he was scoring a 4 in relation to crisis prevention of admission, which means that he was at serious risk of death. So that means that if we didn't know where to start, we've got a pretty good idea straight away just by looking at the data. I won't go into it because you can look at it all later at your leisure. You can also see a lot of concerns around communication and around the service quality. So that makes sense when you think about the fact he's going to hospital, waiting long periods of time, and nothing was really happening very quickly or very effectively or very efficiently. There are a lot of issues around pain and pain awareness. He couldn't tell you, and nobody was really picking up on when he was in severe pain. So what we did, one of the things we did a number of interventions with him, but I thought you'd like to see this one. We used a pain picture, which is something we've developed. And the idea of the pain picture is you work with the family to identify how a person is when they're not in pain and how they are when they are in pain. And it's a really simple tool that you can look at really quickly. GP can look at it, or any department can look at it, and it gives you very specific, bespoke information about the person. So in his case, for example, under behaviour, he wants to sleep all the time, but he becomes restless. He closes his eyes and drops off wherever he is. He has reduced body movement, and he likes to have somebody with him. Quite important information. And there are a number of things that actually are very specific to him, like he makes a gentle wail. Somebody else who's done this on makes no sound at all, cries without tears. So just gives you an idea of things that you can use. I hope you just give you a bit of that. So after we put the pain picture in place, and I'm really running through this very fast because I'm still looking at me. After we put this in place, with a number of other things that we did, the family who gave us the information started to use the pain picture themselves as a sort of checklist. And they found that they were picking up much earlier all the things that they knew were there because they had it on one thing that they could look at. They'd be thinking, well, he's not too good today, let's have a look at the pain picture. Oh, yeah, he's got that, oh, actually, we need to get him to the doctor, or just get him on some antibiotics. And it's reduced his hospital admissions from about once a month to twice in the last 12 months. So it's had a really big impact on him. And you can see the difference in his health inequalities profile. So when you rescore it, it shows you the difference. So the red picture there is how his health inequalities profile looks now. And this is the difference. So if you have a look at crisis in hospital, that was a 4 in the first one, it's a 0 now. That's the best possible outcome for anybody, to be able to get down to no impact on him, on the health inequalities. And you can see that most things have gone down. I'm showing you the rest so you can actually see. Service quality, communication, all those areas have improved. And obviously you can see over on the communication thing that the body pain awareness scores as well. A lot of these things are to do with other people's responses. So the carer's awareness and the carer's response is very important in terms of knowing when somebody's in pain or likely to be in pain to do something about it. And the same with other issues as well. Okay, I'm going to hand over now to Kristen. That was the quickest mystery I've ever done. To make up for days.
Right, I've got a different slide up there.
Oh, sorry, press the button.
So I think, is it you?
Oh, mine.
Oh, right.
Oh, sorry. That's the initiative test.
Okay. I think what we're looking at here, rather than what I'm looking at in front of me, is some of the different ways that you can use the health quality framework in your practice, really, and touching on what Dave was talking about earlier. So rather than just being a measure of outcome, what we're actually finding is that the health quality framework helps you identify what the priorities are for different people as referrals comes in. It helps nurses and other practitioners to manage their cases. And can influence some of the things that Chris and Sue were talking about earlier in terms of combining a health quality profile with your annual health check, so you can start to get a picture over the years around the impact that any individual might be finding, and then linking that into health promotion activity with individuals and groups. Think about the training and education for staff teams in terms of where the biggest areas of need are. And actually what we're finding in Gloucestershire is we're starting to think about the skill mix within the teams in response to the health quality profiles for the population that they're working with. Now on to my slide. When we started to work with the health quality framework, it was very much thinking about demonstrating the outcomes of individual interventions with individual people with learning disabilities. And once we started developing the tool, our kind of second light bulb moment, if you like, was the realisation that the data we were gathering actually presented a real opportunity to start to understand the needs of the wider population of people with learning disabilities. So that might be the needs of the wider population of your own individual caseload as a practitioner, or the needs of the community of people that your service is working with, and actually broader than that. And we've started, if you come to our workshop this afternoon, we can tell you about our understanding of the needs of the people with learning disabilities in the county of Gloucestershire, and we're starting to look at the aggregated needs from the data that we're generating there. So the second element of the tool is the aggregated data element. And what we do there is take the profiles that Gwen's just very quickly shared with you, strip out any identifiable data from that, and start to pull all of that data together for groups of people, whether that be a caseload, a service load, or the county-wide sort of population thing. So it's a separate tool, separate electronic tool, and again, Dave will share some of that with you this afternoon, which looks very much the same. The difference here is that what you're able to select is how you want to slice your data, really. So you can start to look at all of the data you've got in terms of comparing the outcomes by gender, by ethnicity, by age, or by any of the additional comorbidities listed that you've already put in. So it doesn't require you to put any additional data in. It's looking at the data that's already been collected through the individual HEF scores, puts all of that data together, takes out the identifiable information, and then allows you to analyse that data by any one of those measures that you've already put in. And what you can create from that is a profile just the same as the individual profile, but by population. So with the benefit of actually being able to identify what the needs are for an individual, and then, as they talked about earlier on, it kicks out this data which helps us understand what's happening on the bigger picture. And then you can start to actually use some of the numbers to understand what's going on. And this is just some data that we've generated in Gloucestershire for one team. So over a 6-month period, we asked a multidisciplinary team to score just 5 people off each of their caseloads. So that just gave us 45 odd people. And we rescored those people within sort of 3 to 6 months of the initial score, and used the aggregation tool to understand what was happening for that particular group of people over that particular time. And what we were able to show was the difference in outcome by gender. So this particular slide, so what we were able to share with the team after that period was that the overall improvement for the males in that sample from that caseload was 19.3%, and the overall improvement for females was a whopping 48.3%. Now, we don't know why that is, and I think one of the important things about the HEF is that it encourages people to ask questions. It helps you to understand what's going on. But we don't always have the answers to that, but by asking the questions, it helps people to think about what's going on. And actually, in terms of the findings of the confidential inquiry, it's really encouraging to see that for that team, for that group of people over that period of time, they were making such a tremendous difference for women with learning disabilities from that sample. And similarly, the team really liked this slide because what they were able to demonstrate, which they hadn't previously been able to demonstrate with such accuracy, is the improvement or the reduction in exposure to the determinants of health inequalities for all sorts of different presentations, for all sorts of different needs that the people with learning disabilities were being referred to the team for. And if you look at the figures on the right-hand side there, what you can see is that actually they were having a similar level, achieving a similar level of improvement regardless of the particular needs of the people who were coming to the team. So they were as successful in working with people who had sleep problems as they were with working with people who had challenging behaviour. And I think one of the great things about learning disability nurses, particularly community learning disability teams, professionals who work with people with learning disabilities, is the whole range of different needs that come through the door, if you like, and we respond to. And being able to demonstrate the impact that you're having across those range of needs was really popular with the team. And I think we're back to Phil.
Can you hear me? I'm going to run through the next half dozen slides very quickly because I think a lot of this has already been sort of touched on, and as I said earlier, we'll get a lot of workshops this afternoon. I suppose through the presentation this morning, you've seen how it can be applied for clinicians, managers and commissioners and the ways it can be used. So I'm not going to say any more on that because you will pick it up later. I think for me, the service improvement can be found around local populations and how the aggregated data can be used to assist us with that is going to be really important. And we talked at the end about taking it forward again next year around the self-assessment framework and how that can be used. And I suppose at the bottom there about how it's used for professional groups and others to demonstrate their value and their contribution, which was always at the back of our minds from the very start. And I think we truly now do have a tool that will be able to demonstrate that. Mentioned already, the other versions are available, but I think Glenn, you're going to talk on the practice evidence indicator in your session this afternoon, aren't you? You'll be introducing a bit around that this afternoon, so probably not, but it is available. The sequel I know will be picked up by Crispin. And we really are pleased that we've had very positive input with family carers, and really looking forward to that workshop this afternoon because they have really taken this and grasped it and have worked very closely with this on taking it forward. And the feedback that I get, or we get from them, is really great, and it's great to see that it is actually being received well there and see that it can be used in a very effective way. But the further work is underway already, and there's the national rollout across the 4 countries, and I know Scotland and Northern Ireland have booked several of us for next year to come do some work with them on the HEF, and they're looking at ways of rolling it out, and that's why we're really keen here in England to make sure we keep up with that pace as well. It's referenced within the self-assessment framework, within the core service specs. There is an e-learning package currently under development. I'm looking at Dave on that. And you know, there's this debate about the national minimum data set for learning disabilities and whether or not we should replace Thomas LD with the HEF, and that'll be a debate that we'll see taken forward next year. And there are publications in the pipeline, and obviously we need to do more around the cost-benefit analysis, because I think if we can demonstrate that, then you know it gives more power to the tools itself. Research, and we're already talking with Ruth Northway around, and others I should say, around how we can take forward some research. I think we need to obviously see this implemented in more services and try and gather that information and that data to inform that. Because we need to validate it, and that's always going to be a challenge for us until we get sufficient numbers and sufficient information and feedback on it, then that's going to be difficult. So we will be looking at 2 people when they've downloaded it and they're using it to join us in gathering that information. And I think applying it to other groups is really interesting, because we've had interest from across the board, you know, children, young people's services, old people's services, saying that they really like the framework and could they develop something along those lines for their own services. We were lucky, as I said at the very beginning, to have the IHEL information, and their challenges might be different, but it certainly lends itself for that development. And I suppose we've been lucky enough to travel quite far and wide presenting on the HEF, and we were in Melbourne in May this year to present at the International Congress for Nursing. And we had interest from public health in America, and also from a midwife who works with the Indigenous population in Australia, who really felt that, having heard the presentation, that she could use it for that particular group as well. And we are progressing right from an international basis as well. So, you know, there's lots going on, and it is quite an exciting time for us all. There's your website, you can get it on, and I think I'm finishing now, I'm getting contact, I think. Any questions?
Thanks, Phil.